I will share the screen. Okay. Can you all see the screen? I'm sharing my PowerPoint presentation. Yeah. The thing is, I will go with my notes because I have prepared my own notes. The thing is, I have gone through the Ashanaya notes also. That's also good one. So this is the note I prepared with the Anuja madam's lecture. So both are almost same, and this is a easy topic, so you can cover it easily. So we will start with the SEQ, so that will be better. So if you don't hear, because I am from my hometown, if you don't hear what I'm saying, just let me know. So this is the SEQ I have got from 2012 batch, I think. Almost all the SEQs are in the same pattern. So directly they will be mentioning one surgery and they will be asking for pre-op management. And you will also get these questions on this topic in the MCQ and the longest discussion also, especially for my longest discussion, I also got some for 2 to 3 minutes discussion on the pre-op management. So yeah, at any where you can get question. So let's see this. 70-year-old female presented with right lower abdominal pain, found to have carcinoma of the right colon. A decision is made to undergo a right hemicolectomy. So this is part of the questions containing 35 marks. So total out of 100. So what is the pre-op management for this patient? So then we will look for the answer. With that we can study. So this is the pre-op assessment and the management. So what are we going to cover in this topic? Only three. We can categorize all the things what we have to cover into three categories, which are prior to admission. Prior to the admission mean it is done usually 2 to 3 days prior to the admission for the surgery, like even 1 week before, 2 weeks before, even 1 month before, we can do the things what should be done prior to the admission. That is one. The next one is a day before surgery. So the patients usually get admitted the day before this planned surgery. So there are certain things which has to be done on the day before the surgery, and the last thing on the day of surgery. So we will categorize into three category, and we will look each and everything. And prior to the surgery, mean this is like the we are having initiation of the planning for the surgery. It is usually done 2 weeks or 3 weeks or 1 month before the surgery. So what we have to do is consent. This consent is including with the history and the examination. So as usual, we have to do the proper history and examination for the assessment. Then we have to get the consent for the surgery, because without the consent, no need of preparing the patient. So consent means we will get the consent. You know that what are the things should be included in the consent, including that we have to explain what is the procedure, what is the indication of the procedure, and what are the alternatives there. So patient and doctor, it is kind of a discussion. At the end of the discussion, patient has to come forward with the idea what should be done on the patient. So that is we have to give the options. And if you are going for the certain procedure, then what are the pros and cons, advantages and the disadvantages, like a complication. And those are the things we have to cover in the consent. And the second one is the more important, the comorbidities, because usually in the longest discussion and the SEQ, specifically they are asking about the procedures for the surgery which is done under general anesthesia. So we have to have a proper control of the comorbidities. So which are, we know, hypertension and the diabetic. So if we take the diabetic, diabetes should be controlled properly. For that, if the patient is a newly diagnosed patient with the diabetic, then we have to give referral for the physician, and we with the opinion of the physician, we have to start with the drug. Usually what we can do is we can start on the metformin, or if the patient is having the very high blood sugar level, we can go for the directly for the soluble insulin. The target blood sugar level will be 140 to 180. There is no strict value, because the blood glucose level is needed for the proper wound healing. Too much of glucose is not good, but anyway, there should be a certain level. So we are maintaining between 140 to 180. That is the standard level. And if the patient is already on the medication, alteration of the medication should be done. Usually, if there's any other drug other than the insulin and the metformin, we are going for the alteration that I will explain, the drug modification and the investigation. This is the most important part, because in the question also pre-op management, they are asking expecting the set of investigation. What the mistake we do is we write every investigation for all the patient, but they don't expect that, because certain investigations should be done for every patient. Certain investigation should be specifically done for certain group of patient. We don't need to do all the investigation for every patient. For example, I will share other screen. You can catch it easily. This is mine. Can you see the screen? Someone?
Can see.
Can see. So these are the set of investigation. There are a lot of investigation. No need to mention in the long case, or no need to write in the SEQ all the investigation. We have to specifically know what are the indication for writing the investigation. Full blood count should be done in every patient, because we have to have a proper hemoglobin level to do a surgery. Ideally, the level is 13 gram per deciliter. That is the standard value we need before surgery. But practically, that is not possible for every patient. So here, practically, what they are expecting is a 10 gram per deciliter. But ideally, according to the WHO, that is 13 gram per deciliter. That is one set of investigation. And the other one is serum creatine level and the serum electrolytes. So the patient who are undergoing the general anesthesia, we have to do this both investigation for every patient. No need of selection. For every patient who are undergoing major surgery under general anesthesia, we have to go. Usually, we will be questioned on the general patient who are undergoing general anesthesia. So this one. And other thing is PTINR, clotting profile. It should not be done in every patient. It should be done in a patient who are having a problem with the coagulation. The patient who are having the liver cell disease, or patient who are having the family history of coagulopathy, or past history of bleeding disorder, then we have to go for the PTINR. Not for every patient, but practically in our ward, for the patient who are undergoing general anesthesia, we are doing each and every investigation for everyone. But while giving the answer, don't tell all the investigation. These are only indicated for the indication I have told. Then the ECG. ECG, we have to categorize for the there are indications for the male patient and the female patient. If we take the female patient, if the patient is postmenopausal, we have to do the ECG. For the male patient, if the age is more than 40, we have to go for the ECG. And also, if the patient is a known patient with comorbidities and the heart disease, then we have to go for definitely for the ECG. No any other indication for the ECG, especially not in every patient. Don't mention that in SEQ and or in a long case. If you find any indication only, just mention ECG. Otherwise, no need. When we are doing the ECG, with the results of the ECG, if there are any problems or abnormality in the ECG, then we have to further investigate the patient with 2D echocardiogram, and we have to do the cardiology referral. What we usually do is we first do the get the 2D echocardiogram done, then we will do the cardiology referral, because sometimes the cardiology unit may need the 2D echoes and the referral will be delayed. For that, practically what we are doing is we are directly doing the 2D echo and send the patient with the 2D echo to the cardiology for the referral. And the liver function test. Liver function test also not needed in every patient. We have to remember, because that is only indicated in a patient who are having problems with according to the hepatobiliary system. For patients like alcoholic patients who are having the chronic liver cell disease. So if you are suspecting a patient to be having some kind of liver pathology, then we can go for the liver function test. Otherwise, no need of doing the liver function test in every patient. The same other investigation, chest X-ray. No need to do any for every patient, but we have to look for the indication. So if the patient is having a cardiac or respiratory disease, or if they have mentioned in the history or in the question the patient is having any respiratory pathology, or if the patient is having a history of chronic smoking, then we can proceed with the chest X-ray. Otherwise, no need. Then the lung function test, that is also the same as the chest X-ray. If it's indicated only, we will go for the lung function test. Otherwise, no need to do lung function test in every patient. Then the referral, then wait. And then we will come to the rehabilitation. The rehabilitation means after doing all the investigation, we have to prepare the patient for the surgery. Patient should be fit for the surgery. That is the procedure we call the prehabilitation, not a prehabilitation. We have to do, and we have to make the patient fit for the surgery. Rehabilitation contains many areas. The most important area is the anemia correction. So as I mentioned, we have to have the ideal target of 13 gram per deciliter. But even if we can't achieve that, more than 10 gram per deciliter practically is enough. For the anemia correction, but how are we going to do it is the thing. If we have a long period of time before the surgery, we can correct it with the oral iron. But if we have a short period of time before surgery, we can go for the correction with the IV iron or blood transfusion. So as we also would have studied in the Ginen of Assess, the same thing for the here also anemia correction. Then the nutritional modification. Ideally, what we have to do is we have to calculate the daily calorie requirement and the micronutrients requirements like iron. Then we have to prepare a specific diet. But what we are doing is we are doing a referral to the nutritionist and get it done with them. So I think for our exam purpose, we don't need to remember all these calculations for the SEQ or the long case. Just we have to remember that we have to prepare the patient nutritionally. So we have to calculate it ideally, but what we can do is we can do the referral to the nutritionist and we can get it done. So no need to remember all these equations. Just remember that we have to do the nutrition referral. And chest physiotherapy, it should be done in every patient. Chest physiotherapy, how we are doing is, we are usually doing is with the incentive spirometry. So we know that 3 balls kind of instruments we are using. We are giving every patient who are undergoing general anesthesia. And that is to improve the lung capacity before the surgery, because the lung capacity should be enough for the normal function of the liver to prevent the aspiration pneumonia in the after the surgery. So chest physiotherapy is very, very important. And the exercise program. Exercise program is ideally what should be done is every patient who are undergoing surgery should do 30 minutes of at least 30 minutes of regular exercise at least 5 days in a week. Not all the 7 days, 5 days in a week is enough. But if the patient is willing to do, he or she can do more exercise. This is a minimum exercise the patient should undergo. Then I have explained about the glycemic control. Sorry, I have missed the hypertension. With the comorbidities, hypertension also should be controlled. What is the target is, for the diabetic patient, we are having a lower target, and for the other patients, we are having somewhat of a higher target. For the diabetic patient, 130/80 is the target. For others, 140/90. So here is also we are doing the alteration in the medication, and we are getting a target of this blood pressure prior to the surgery. At least ideally we have to have 2 weeks of blood pressure control prior to the surgery. We can do the referral to the physician as well. That is usually done practically in our ward, in a surgical ward. And smoking cessation. Smoking is a bit of problem because ideally it should be done for 6 weeks. Patient should be off from smoking for 6 weeks, but that is practically impossible because whatever the we tell, patients will be continue smoking for some time. So what they advise is, as much as possible time, patient should be off from smoking. So this is ideal 6 weeks, but even 1 week, if the patient is willing to off from smoking, that is welcome. Okay, that is smoking cessation. And those are the things that what we are doing prior to the surgical admission. So I think you would have got it. Then the next one is a day before surgery. If you take day before surgery, that is done. The patient usually get admitted the day before the surgery around morning or evening time. So up to the surgical date morning, what are the procedures? What we do is coming under the day before surgery. The important one is the DVT prophylaxis, not done for every patient. If the patient is having a risk for the DVT deep vein thrombosis, we have to start. There are two options we are using. Low molecular weight heparin we can use prophylaxically, or DVT stockings also we can use. And the and other one is the theatre list. That is favorite questions from most of the surgeons, because there are 3 copies of the theatre list. One should be in the ward, one should be with the anesthetist, and one should be sent to the theatre. Original copy will be sent to the theatre. So that is theatre list. Theatre list should be prepared prior to the day of surgery, and with the use of the theatre list only, the anesthetist will come and do the referral with the patient. And the pre-medication. Pre-medication, I will show it. Yes. Pre-medication, there are several pre-medication we are starting. The first one is the antiemetics to prevent the vomiting. It is also not started in every patient. We have to assess the risk of the post-operative nausea and vomiting. If there is high risk only, we are starting the antiemetics. For patients who are undergoing retinal surgery, squint surgery, laparoscopic surgery, so any surgeries related to the balance system like inner ear, middle ear, then we will start with the antiemetic. But here I think we are starting for most of the patients the antiemetic. The first choice of drug is IV ondansetron with IV dexamethasone. If there is a high risk only, then we will add metoclopramide. Metoclopramide is not a first line drug as an antiemetic. That we have to remember. Then anti-aspirations to prevent the aspiration and the aspiration pneumonia following that. So we would have heard this in mostly in the cesarean section and pregnancy related surgery. So as any patients who are having the intra-abdominal mass should be started on the anti-aspiration medication. The drug of choice, there are vast of choice, but usually we are using in our ward is antihistamine, metoclopramide, and the sodium citrate. Sodium citrate is usually given at a theater before the onset of the surgery. And the third one is the anxiolytic. We are using the drug midazolam. It is also not started in every patient who are having hypertension, cardiac disease, and the patients who are anxious about the surgery, usually the female patients, elderly patients, we can start, because if they get anxious, their blood pressure will be altered during the surgery. That will be a help for the anesthetist. So they will be preferring starting the anxiolytics. Then the pre-medication we have finished. Then the special preparation. I have mentioned ICU because not every patient who are undergoing general anesthesia, as we know, no need of ICU bed. If there is indication, if we suspect a high risk surgery, then we will prophylactically book an ICU bed prior to the surgery. Then we will go for the surgery. If the patient need it, then we will use the ICU bed. Otherwise, we can cancel it. That is. Then other one is a bowel preparation. Bowel preparation, according to the ERAS protocol, we know that early recovery after surgery, that is a protocol. Now they are not preferring the bowel preparation. Without the bowel preparation, they are preferring the surgery. But in certain units, certain procedures, we have to do the bowel preparation. I think no need to explain here, because when you are doing the rectal malignancy or GI malignancy, then you will study the bowel preparation. So bowel preparation is needed in certain situation. The last one is the other one is the fasting. Fasting, we know 6 hours, 2 hours thing, 6 hours for the solids and 2 hours for the clear fluids. That is common for major surgeries. But in certain procedures, there will be a change, like the patient who are having dysphagia due to the malignancy, achalasia cardia. that will be done during when you are doing the dysphagia. So no need to make it complex here. So have you all understood? I think at the end I will discuss the answer for the SEQ. Just I am going through what we have to cover under the each and every topic. I think you got it. And if you want, you can ask anything. If I know, I will let you know. Okay. And the important thing, what we have to do, what should be done on the day of surgery. So important thing is antibiotic prophylaxis. This is important topic because it is commonly asked in the MCQ. What is the time of the antibiotic prophylaxis? Who are the patients should be given? So repeatedly they are asking questions on the antibiotic prophylaxis. So according to the surgery can be classified as we all know into 4 categories: clean surgery, clean contaminated surgery, contaminated, and the dirty surgery, according to the level of the sterile. So what we have to do is clean surgery mean for example thyroidectomy, that is an area which is considered as a pure sterile. Actually it doesn't need any antibiotic prophylaxis. That's for example thyroidectomy. But certain patients who have certain conditions need antibiotic prophylaxis despite of surgery. For like immunocompromised patients who are diagnosed patients with HIV, who are on immunosuppressive drugs like steroids for long term, then we have to start on the antibiotic prophylaxis for the clean surgery. Otherwise, other thing is increased risk of infective endocarditis. And when we are introducing a foreign body for like mesh repair surgeries, though even if you consider it as a sterile region, we will start the antibiotic prophylaxis because of as the introductions of the mesh foreign body. So these are the 3 indications where we can consider the antibiotic prophylaxis in a clean surgery. Other than this, there is no indication for us to start the antibiotic prophylaxis in a clean surgery. That you have to know that. Then other categories, clean contaminated surgery. For this kind of surgery, we are starting the prophylactic antibiotic, not a therapeutic dose of antibiotic. We are starting the prophylactic dose of antibiotic. You will be studying each and every category again and the type of the example for the surgery in later. So no need to spend a lot of time on that. And the other 2, contaminated and the dirty surgery. For example, we are suspecting a bowel rupture and we are opening the abdomen. So we are considering it as a dirty surgery. Then for that kind of surgery, dirty surgery and a contaminated surgery, we have to start the therapeutic dose, not the prophylactic dose. If we are starting the therapeutic dose, what we have to do is even after the surgery, we have to continue the therapeutic dose for some time. It may be 5 days or 7 days. That is a difference we have to know, because I think I have some question also repeatedly they are asking this kind of questions again and again. So you may see some questions on this topic as well. And how many doses? Usually when we are starting the antibiotic as a prophylaxis, we are giving single dose. But when we consider the time of surgery, we can go for maximum of 3 doses, including the first dose. 3 doses is the maximum dose we are going as an antibiotic prophylaxis. The indication for the 3 doses of antibiotic is, one is the surgery is a prolonged surgery. For example, if it goes more than 4 hours, or if we consider there is a significant blood loss, then we have to go for the repeated dose. Otherwise, we have to do single dose of antibiotics, and the certain antibiotics is given at the time of induction. That is also MCQ point. They have asked 2 times in the past. Because why we are giving the antibiotic during the induction is, the reason is we have to have the maximum concentration of antibiotic in our body when we are putting the incision on the patient. So that is the reason that why we are giving the antibiotics at the time of induction. So for each and every surgery, we are starting putting the antibiotic prophylaxis at the time of induction. Just keep it remember. And these 2 things, the last 2 things, carbohydrate loading and cleaning of the skin. Cleaning of the skin is not recommended in every patient. Even if you want to do, if the surgeon want to do the cleaning of the skin, it should be done on the table before the surgery. It should not be done in the ward, and we should not send the patient after cleaning the skin to the ward, to the theater. ideally the patient should be sent to the theater. On the table, the skin should be clean. But the problem is why they are not recommending the cleaning the skin, because it increases the risk of infection. That's why for all the surgery, they are not recommending cleaning the skin. But even if you want to do, it should be done on the table, theater table. And the carbohydrate loading, this is important thing. There is a special preparation that what we have used in our prof unit for the carbohydrate loading, but that is not available now. So currently what they are using is I think ORS solutions, oral rehydration solution is the one they are using currently. I got this information from the nurse. So how they are doing is the day before the surgery, they are giving 800 milliliter of ORS. And on the day of the surgery, 2 hours before the surgery, they are giving 200 milliliter of ORS. That's what they are preparing with the carbohydrate loading. And only contraindicated for the carbohydrate loading is a diabetic patient. Diabetic patients, we are not doing the carbohydrate loading because they can't tolerate the high blood glucose level. Okay. And the last thing, asthma. If the patient, we know that if the patient is diagnosed patient have a history of asthma, we can do the nebulizations prior to the surgery, and we can send the patient to the theater. Okay. I think I will. I think that's all. That what the pre-op preparation in a patient waiting for the surgery. If you want to ask any question, you can ask. And I will come to the question, the SEQ one. The 70-year-old female presented with right lower abdominal pain found to have carcinoma of the right colon. A decision is made to undergo a right hemicolectomy. So what we have to when you are SEQ, we have to, because nowadays our SEQs have 8 questions, so we don't have the much time to write each and everything in SEQ. So we have to plan and write it. So they are asking answer for 35 questions. So what we are to do is we can categorize as I mentioned into 3 parts: prior to the admission, the day before admission, on the day of admission, and we can mention the things what should be done. And you have to and also when you are writing the answer, as I told earlier, don't write each and every investigation. In the case scenario, if there will be some points to mention to catch, not to do some investigation, but to do certain investigation, we have to catch those points. With those points, we can prepare our SEQ. So the most important thing is don't write each and every investigation in every patient. That will make the examiners more fed up. Even in the long case discussion as well, the same thing. Okay. I think we can move to the MCQ. Can you all see? Hello? Hello? I'm not sure whether my connection is good. Anyone? Hello, anyone? Can you all hear me?
Yeah, we can hear you.
Okay. Yeah. Then we will.
Can you please tell me the SEQ and the answering method again?
We will go through the MCQ. That's a good one. We can understand a lot of things in the MCQ. So let's see the question. Okay. So this is a question. 58-year-old male is planned to undergo an inguinal hernia repair. So what factors would prevent him undergoing a day surgery? So I have prepared a slide for the daycare surgery. So I will let you know that day surgery means that is a name for given for a certain type of surgery. For the surgery where the admission and the discharge, which both happen on the same day. Like the patient get admitted on the morning and get the surgery done and get discharged on the evening. So that is considered as a day surgery. So we have to think, we have to know certain factors regarding the day surgery, because they have asked in the past. I think I have seen only one MCQ. In the future, they may ask. So age is not a limiting factor, because we can think that the elderly patients who are above the age of 80 can't go under day surgery. Not like that. Age is not a limiting factor. Usually, we are going for the day surgery patient who are ASA1 and ASA2 class patient, because they are fit for the surgery and we can easily manage the patient. They don't have much of complication. So we prefer ASA1 and ASA2 class patients for the day surgery. And the blood pressure should be below 180 by 110 to go with the day surgery. And if the patient is having the cardiovascular system or respiratory diseases, we don't prefer the day surgery, but even with a proper prior anesthetic referral, even we can consider day surgery. So that is not a contraindication of having the cardiovascular or respiratory disease. And the well-controlled diabetic condition is needed, like HbA1c less than 8.5. And also the epilepsy should be controlled. Even if the patient is not having proper epilepsy control, we should do a referral like what we have done for the cardiovascular system respiratory disease patient. And we have to make sure that the patient is having a home support after the discharge. Then we can go for the day surgery. And the preferred BMI for the patient who are undergoing is less than 40. And the most important thing for the day surgery is the social support. If we are going to discharge a patient, we have to make sure someone is there at home, or the patient, the place where the patient is staying, there's a person to support the patient. Otherwise, we can't include the patient under a day surgery program. And ideally, the surgery should not be prolonged more than 2 hours. It should be a short surgery. Like the surgery like carpal tunnel syndrome, the surgery we are seeing in the minor table. So those are the day surgery. These are the indications that what we are expecting. So this is the whole MCQ regarding that. So, but they have asked directly the points. If we know that, we can directly answer. Uncontrolled diabetic mellitus. So uncontrolled means they haven't mentioned the exact value. Uncontrolled means I have taken it as a HbA1c more than 8.5. So we can't go for the daycare surgery. It should be controlled less than 8.5. Then we can go for day surgery. Otherwise, we have to admit the patient and we have to do as a elective routine surgery, not a day surgery. Then the obesity BMI more than 30. I'm not sure about this answer, because they can't give an answer like more than 30 because we don't know the exact value. I have taken it as a false, because I took it as a less than 40. So it is not a factor that prevent him from the day surgery. So if the BMI is less than 40, the patient can go for day surgery. And history of smoking, that is not a contraindication for the day surgery. So even if the patient having a history of smoking with the respiratory disease, with the prior anesthetic referral, we can go for the day surgery. There is no contraindication for that. This is the most important thing I told: social support. Live alone at home. Even if the patient is very fit for the surgery, no complication, if there is no support or social support, a person who to care the person at home, we can't go for the day surgery. We have to go for the routine surgery. So that is true. And body mass index more than 30. I think there's a mistake in the answer. Again, the same answer as B. So that is also false. So if they want to ask the questions on this topic, they will ask directly on these factors. Mostly they will ask MCQ. Rarely they can ask the SPR on the single best response on this topic. So just remember those stuffs. No need to remember, just remember the fact, so we can go for the answering. Okay, if you won't know anything on this day surgery. And also they haven't mentioned any answers regarding the time factor. We have to consider the time factor as well. If they are giving a major surgery under general anesthesia, we can go for the day surgery. Like that, repeatedly, if they want to ask, they will ask on the same topic and same fact, the answers will be there. Just remember those stuff. Then we will move to the second question. 75 years old patient treated for hypertension and ischemic heart disease is scheduled to undergo transurethral resection of prostate under spinal anesthesia. Which drug should be discontinued at least 1 week? I think I have forgotten that. Here I will tell. So drug modification. Drug modification is very, very important if you are going for surgery. There are certain drugs we have to modify. The first one is the oral contraceptive pills. That is for the female. If the patient, if the female patient is on the OCP, it should be withdrawn 1 month prior to the surgery. That is important. Otherwise, we can't go for the surgery ideally. And other drugs, we have to consider warfarin. Warfarin should be stopped before 5 days of the surgery. After stopping the warfarin, we have to convert it to the low molecular weight heparin. That is a way. We are stopping warfarin 5 days prior to the surgery, and we are converting into the low molecular weight heparin, and we are continuing until the day of surgery. And if we are giving the patient therapeutic dose of low molecular weight heparin, we have to stop the low molecular weight heparin also 24 hours prior to the surgery. That is the way. But if you are using the prophylactic dose of low molecular weight heparin for the as a DVT prophylaxis, we have to stop 12 hours before the surgery. Can you all hear? I think I got a message that your connection is unstable.
Can you please tell me again about this drug?
Oral contraceptive pill. Then I will start from the OCP. OCP, what we have to do is, OCP, we have to withdraw the patient from the OCP 1 month prior to the surgery. That is one thing regarding the OCP. So that is in the female patient, we have to get the history we have to get the information in the history. And if the patient is on OCP, we have to stop it 1 month prior to the surgery. The next one is anticoagulant. The problem is with the warfarin. Warfarin, we have to stop 5 days prior to the surgery. Before 5 days, we have to stop warfarin, and we have to convert the warfarin into the low molecular weight heparin therapeutic dose, kilogram per day. I think that's a dose for as a correct. And even the low molecular weight heparin should be withdrawn 24 hours prior to the surgery. So what does mean is, when the patient is going for the surgery, the patient is withdrawn from the warfarin and the low molecular weight heparin both. He or she should be off from both the heparin as a prophylactic one for the DVT prophylaxis. We already told we can use stockings or the low molecular weight heparin. If we are giving as a prophylactic dose, we have to stop it 12 hours before the surgery. Warfarin or low molecular weight heparin, at the time of again it will be started after 24 hours. Then we will be talking the post of management. Then other drug is then we have to drug like glycoside can't continue those drugs. Metformin can be continued, but other drugs should be converted to the metformin or soluble insulin. Then after the surgery, then again we can start it. Metformin also can be continued throughout the surgery. Other two main drugs, aspirin and clopidogrel. Aspirin can be continued throughout the surgery. No need to Hello? Now can you all hear me? I got disconnected. Anyone?
Yeah, we can hear you.
What is the last thing that you heard from me?
You said about metformin can continue throughout the
Okay.
surgery. Then you stop. There's a like regarding this aspirin and clopidogrel stuff.
Okay. Then I will continue with the aspirin and the clopidogrel. I think you can see the screen as well. So aspirin can be continued. There are several MCQs telling that aspirin should be stopped. That is false. Aspirin can be continued. Clopidogrel should be stopped 5 days prior to the surgery. There is a confusion because I think 1 or 2 years back, the indication of stopping clopidogrel was 7 days. 7 days prior to the surgery, we have to stop. But now it has been changed. Only 5 days prior to the surgery, enough to stop clopidogrel. Only 5 days. That just make it remember, not 7 days. Okay. Then we can move back to the MCQ. Okay. Which drug should be discontinued at least 1 week? 1 week thing is they have mentioned because regarding the clopidogrel, because initially it was 7 days. So if we can now take it as a 5 days. So take the question as a 5 days. Then let's see the answer. Okay. So aspirin should be false because it can be continued. No need of stopping aspirin as an indication for the surgery. Then stencil, I don't know what kind of drug this stencil. I have heard stencil as some kind of drug that we are using for the throat discomfort. I don't know actually. And the clopidogrel, I think it should have been true at the time because initially it was stopped 7 days prior to the surgery. Now it is 5 days. So currently we will take again as a true because if we take the question as a 5 days. Okay. Then warfarin again 5 days. So if the question is mentioned as a 5 days, it will again come as a true. Warfarin, clopidogrel, both 5 days. And the heparin, no need to stop before 5 days. If it is, as I said, if it's a therapeutic dose, we can continue until 24 hours prior to the surgery. If it's a prophylactic dose, we can continue until 12 hours prior to the surgery. Okay. If there is any questions or doubts, just ask me because I'm just telling the thing, but I'm not. Sometimes I also may make mistakes. So if you just mention me. The third question, prophylactic antibiotics given before surgery. I think this is SPRO. I know this is also true or false question. Best given as a loading dose 2 hours before surgery. So I mentioned this. It is given at the time of induction because to have a maximum concentration of the antibiotic while we are putting the incision. That is an indication for giving the antibiotics at the time of induction. So that is totally wrong. Broad spectrum antibiotics are contraindicated, not a contraindication. Usually we are using the narrow spectrum, but as they mentioned is as contraindicated, that is false. Because sometimes we can go for the broad spectrum antibiotics. So contraindication is a word that make the statements as a false. Maximum given 3 doses. Mentioned usually we are giving going for the 1 dose, but if the surgery is a prolonged surgery more than 4 hours, or if the patient is having a significant blood loss, then we can go for the repeated dose up to 3 doses. That is a maximum dose ideally we are giving. So that is true. Increase the risk of bacterial resistance. So whatever the incidence, when we are using the antibiotics, we are increasing the risk of bacterial resistance. So that is anyway true. Okay. No indication in clean surgery. So that is false because I told 3 indication in a clean surgery where we have to use prophylactic antibiotics if there is a risk of infective endocarditis or if the patient is having immunocompressive status, then we have to go for the prophylactic antibiotics even in the clean surgery. So no indication in clean surgery, that is totally wrong, false. There are certain 3 indications where we have to use. So if you have any questions or doubt, just ask me. Okay. The patient is being prepared to undergo ERCP the following day. His current INR is 2.8. What is or are your solution to this problem? I think we can discuss this MCQ later because we will study the ERCP in in detail when we are studying the pancreatic CA. So I think I can skip this. Okay. This one. 45-year-old male having diabetic nephropathy plan to undergo contrast CT, CECT, which of the following best option minimize the risk of contrast nephropathy? So the patient is already having the diabetic nephropathy, and we are planning to do a CECT. Contrast is a killing factor, so it can worsen the diabetic nephropathy, and patients can end up in the acute kidney injury. For that, we have to do some certain things to prevent the acute kidney injury. So what are the options we are having? That is the MCQ. So usually, I will explain this question. To prevent the diabetic nephropathy, we can go for 3 options. First one is a hydration. Hydrate the patients properly with a normal saline, 0.9% sodium chloride. That is the best option. Or we can use N-acetylcysteine, NAC. So that is not recommended by everyone. Hydration is recommended by everyone, not NAC. The third option is sodium bicarbonate, NaHCO3. So the later two, sodium bicarbonate, NAC, are not indicated, used by in each and every unit. So we have to go for the hydration properly with 0.9% sodium chloride. If it other options, some consultant or surgeons may use other 2 options. The best and the first in the management option is hydration. So the options are perioperative 0.9% normal saline, sodium chloride. That is true. That is the best option. Post-operative hemodialysis. No, post-operatively, no need to, nothing can be done to prevent that. So everything should be done to prevent that pre-operatively. So that is false. Pre-operative acetylcholine. So that answer should be N-acetylcysteine. So that is not a good option comparing to the normal saline. So again, the best answer will be the A. And the post-operative furosemide. Furosemide is not a good option because it is a diuresis. When we are doing the diuresis in patients who are undergoing the contrast study, it will worsen the acute kidney injury because we have to have the good amount of volume to distribute the contrast toward the body. So we have to have the good amount of hydration, not the diuresis. So that is totally a false answer. The last one is sodium bicarbonate. This is also option, but out of 3, NAC, normal saline, sodium bicarbonate, hydration is the best and the first option. So we can go for A without any question. So any question you can ask. Okay, this is because there are lot of preparations in the surgery. We know that upper G endoscopy, lower G endoscopy, ERCP, contrast enhanced CT. The first 3 investigation we don't need to study here because you would study in some other topics like dysphagia and the pancreatic CA. I will tell something about the CECT, contrast enhanced CT, because the problem is only with the CECT, not the non-NCCT, because the problem is with the contrast. So what we have to do is we have to get the written informed consent prior to the procedure. As I mentioned, all the things should be explained to the patient and written informed consent should be taken. And we have to put a green color cannula. Then for the usually, as usual, we have to go for the fasting, 6 hours and the 2-hour fasting. And there are 2 problems with the contrast because contrast can worsen the allergy, and it can even lead to the anaphylaxis. The second problem is the acute kidney injury. So we have to take a proper history and the examination, and we have to find if there is any risk factors or past history of allergy or any problems related to the kidney. So if we identify specifically, we have to do the anesthetic referral and we have to prepare the patient. Ideally, we are doing the anesthetic referral, then they will refer back us what should be done. So we have to know ideally what should be done. If the patient is allergic, it is not allergic, we have to prepare the patients with the steroids, which is an immunosuppressive drug. So that is the way of preparations with the steroids depend on how long we have before the procedure. If you are going to do the CECT today, and if you are found to have the patients having allergic to the any kind of food or drugs today, then we can't go for the oral prednisolone. Then we have to go for the IV preparation. IV prednisolone, we have to give 12 milligram, 12 hour and 2 hour before. I think I will make sure just like so. Can't remember the exact dose. IV preparation. Then if we have a time, like if you have enough time to prepare the patient for the CECT, like at least if we have 3 days prior to the procedure, then we can go for the oral preparation. Oral prednisolone, we have to give 10 milligram TDS for 3 days. Then we can go for the procedure. Then I will let know the dose of the IV. And if the patient is asthmatic, then we have to nebulize the patient and we have to go for this procedure. Then the acute kidney injury, then if the patient is having any risk factor, what we have to do is, first we have to do the serum creatinine level. We have to look at the serum creatinine level. According to the level, we have to decide whether we have to prepare the patient for the regarding the acute kidney injury. The best preparation method, as I mentioned, again, the hydration, nothing else. But if the surgeon or if the unit protocol is there, then we can go for the NEC and the sodium bicarbonate. But the best option is hydration with normal saline. Then I think you have got it. If any question, just ask me. Then regarding the prophylactic antibiotics, MC question, best administered in the ward before sending the patient to the theatre for a right hemicolectomy. Again, the repeated stem. It is given at the time of induction. I also told the indication. Erythromycin is used in post-plenectomy patients who are allergic to penicillin. Yes, if the patient is allergic to penicillin, we can go for the cephalosporin because there can be cross reaction. So we have to go for the other option. The best option is erythromycin. So that stem is correct. Post-plenectomy patient is the problem is capsulated organism. So we have to give the antibiotics which can cover the capsulated organism. So penicillin, cephalosporin, erythromycin can cover. So as the penicillin, if it's the patient is allergic to penicillin, we can't use go for cephalosporin. There will be a cross reaction. So erythromycin is a good option. The intravenous metronidazole is used in inguinal hernial repair. I'm also not sure about the answer. So if someone know the answer, just let me know. I took it as a false because not used all the time. The intravenous metronidazole as a prophylactic antibiotics in the inguinal hernial repair only used if you are using a mesh, and not commonly used metronidazole for that kind of surgery. But we can't say that we can't go for intravenous metronidazole. So I'm also not sure about the answer. So I discussed with the SR. He also told it would be false in questions per se. So if someone knows any other explanation, just let me know. Other one is nitrofurantoin is given to prevent recurrent UTI. So we have studied 1,000 times, even in the pediatrics. Nitrofurantoin is used as an antiseptic to prevent the recurrent UTI. So they have asked in the surgery. So that is true. There are several options. Cefalexin we can use. Nitrofurantoin is other option. Okay. Not indicated in thyroidectomy. So I took it as a true because directly thyroidectomy is not an indication for prophylactic antibiotics because as it is a clean surgery. But there is a little confusion because even in thyroidectomy, there are 3 indications as I told earlier. We can go for the prophylactic antibiotics. But anyway, I thought they are asking directly for the thyroidectomy. Thyroidectomy per se, it's not an indication for the prophylactic antibiotic. Okay. So this is, I have already told this. So MC, I think this is the last question. 50 kilogram male awaiting colonic surgery. Which of the following is most likely to reduce risk of surgical site infection? So mechanical bowel preparation, it is not preferred it is not preferred anymore because there are complications with the mechanical bowel preparation. So according to the ERAS protocol, we are not preferring the mechanical bowel preparation. Even if we do, that is not to prevent the risk of surgical site infection. that is to make the surgery more easier, to make the surgery access more easier. So that is not the answer. Preoperative carbohydrate loading, that is to promote the healing, not to associated with this surgical site infection. So that is also false answer. That is to improve the post-operative healing. And preoperative nutrition, so there can be some kind of support for the prevention of surgical site infections with a better nutrition, but that is not a better answer for this, because nutrition is to promote again the healing. If the patient has a good nutrition, the healing will be promoted. Shaving the site, I told this is other way around, because if you are doing the shaving of the site of the surgery, that increases the risk of infection. So that is totally wrong. So the last option is the prophylactic antibiotic. That is the best option that we are doing to prevent the surgical site infection. So out of 5, that is also easy MCQ. If any question, just ask me. So this is the SEQ I told, because we have studied a lot of things. You have to go through your question, because sometime in each and every question they may mention some kind of information to decide what kind of investigation we have to go for. Not every patient is indicated for every investigation. There are certain investigation like full blood count, serum electrolyte, serum creatine for every patient. No need to do every investigation for each and every patient. So just remember that with that idea, you can plan your SEQ answer. No strict and fast rules to write a certain answer. Even in the long case, the same thing. They may ask certain question. They may expect, because our this is done, the class for us done by Anuja madam. So you just can tell the answer and you can argue that. So these are the indications. No need of doing all the investigation. That's what I did in my long case. Okay, that will be helpful. The same question, no any change or trick questions that they are asking. They are mentioning a case scenario and they are mentioning what kind of surgery. Most of all of the surgeries are surgeries which have to be done under general anesthesia, and directly they are asking outline how you would prepare this patient for colectomy. So no, the previous questions for the right hemicolectomy, this is colectomy. So the same answer, just go through the case scenario. And if you want to write the answer, just rationalize your answer. Don't mention unnecessary investigation. If you keep it in mind, that's more than enough. And this is only the 30 marks question. So just don't mention each and everything. Just give an overall idea. Okay. So 50-year-old undergo a transhiatal esophagectomy for carcinoma via midline laparotomy. List the risk factors that you would lead to poor 30-day perioperative outcome. Perioperative period mean preoperative, intraoperative, perioperative. Altogether, the 3 periods altogether, it's called the perioperative. So they have just asked the list of factors. So whatever the factors which can make the surgery more complicated can come as an answer for these questions. Like each and everything we can go for poor nutrition, poor hemoglobin level, comorbidities, and the core diseases like cardiovascular, respiratory disease, smoking, and continuing the drugs that we have mentioned, which has to be stopped, and the surgical technique, and after the surgery, immobilizations kind of thing, getting delayed in the mobilization. So you can list the factors. They are expecting maximum of 5 factors. So you can answer that. Whatever we have studied, you can mention that. The same question, explain how would you optimize the modifiable risk factors. You just go through the note and you just see what are the factors which can be modified. For example, hemoglobin level and the nutrition level and the comorbidities, and they are asking how would you optimize. So that what we have studied how to do that. So just mention, and always keep in remember the content. What is the content you have to write? This is only 15 and 20 marks. So don't waste a lot of time to mention everything. So otherwise you will miss the time to write the answers for the next question. Okay. The same question. per rectum of 3 months duration. Outline the preoperative preparation of this patient. Straightforward question. There is no any trick. This is the answer that have been prepared by the 2015 batch. So I have given the SEQ with the answer. I think I will give this slide as well. I think you may have this slide. So if you want, I will give it. Just go through that. The same question. Here, what they have mentioned is they have given a surgery, and the first question was what measures can be taken pre-operative to improve his respiratory function if he has seen this patient 6 weeks prior at the surgical clinic. So this is we have enough time to prepare this patients properly, 6 weeks time. So whatever the things that we have studied regarding the respiratory system, we can mention that. But just remember that is only 20 marks. So just give an overall idea. Like we can do the referral, and we can do the smoking cessation, we can do the chest physiotherapy, and if we need, we can go for the lung function test, chest x-ray. So these are the things related to the respiratory. So they have separated this question and asked regarding the respiratory function separately. So just mention that. This is the question. Giving reason, outline the investigation that you would request for this patient. Just see, they have given 40 marks for this patient because in the question they have mentioned the patient has a BMI 35, chronic smoker, and he's having a COPD, hypertension, type 2 diabetes mellitus, and he's having all the medication. So this is a complicated patient. So all the investigation what we have done, you can go for the investigation. Chest X-ray, lung function, everything you can go for, because the patient is having the respiratory disease and the diabetic, uncontrolled hypertension. So you can go for that. And how would you prepare him for the surgery? So again, the same thing. You have to better categorize and write it prior to the admission, the day before the admission, and on the day of admission. So if you categorize and write it, that it will be easy for you. So I think that's all. I think I will share these slides to someone. So I think you can go through. If you the thing is, I will share my notes also, but no need to go through my notes, because already you would have prepared a notes. Just if you want to make any change, just make a change and keep your notes. Don't go for a new note after that. So just study your notes. That will be more helpful, and all the questions will be easy. So all the best. So if you want to ask, just ask me, or even you can message me regarding this topic. Nimant, I think we can finish now. Time is okay. It's almost 6 minutes more. Go. Nimanta, shall we stop? Okay. Okay, thank you.